What I want to talk to you a little bit about is kind of where we are and what we as both providers and we as family members and we as service folks to our families with children and adults with special health care needs are going to need to be thinking about and looking at as we go through the next few years. And it took me 14 hours to get home from Washington yesterday, which is abnormal, but as I'm in the Atlanta airport, I hear that song, "It's the End of the World as We Know It." And I don't know whether to relate that to air travel or to healthcare, but it is a changing world. It is a changing set of dynamics from a lot of different aspects. So for me, from the provider side, the exciting thing in the last 21 years for me is the fact that we have come so far in treatments and therapies and interventions and disease identification that our children are living to be adults. And one of the biggest challenges we have at children's hospitals around the country is our children are aging out of the pediatric programs and having to go to the adult side, and our adult docs and teams do not know how to take care of our now adult children. So that's something I can tell you from the provider side. Our folks across the country are all trying to find a better way to make that work and to train our adult partners now. That's something they're not used to doing. So there's education going on in a lot of different places. And as I sat next to a family on the plane in D.C. going up, they were in a situation where they really wanted to go back to their pediatric team. So it's just, we have some bridges to build and we have some training to do, but we're going to get there. So it may be the end of the world as we know it, but it's also Cirque du Soleil healthcare, which is, how many of you all have been to a Cirque du Soleil performance? Okay, Cirque du Soleil in French is Dance of the Sun. And that's kind of, we are in the dance of the sun with respect to healthcare as for the next 5 years and longer. So one of the key things I want to start with is kind of where we are on the federal legislation and what the assumptions were, and then how it trickles down, and then what our challenges and opportunities are. So the first key assumptions in the healthcare reform bill last year are that everybody that are residents or citizens of the United States would have access to health care coverage. Not just emergency room or doctor access, but they would actually have an insurance card. And then the second thing is cost. Now the cost piece is a bigger discussion because costs aren't really defined, but we want our health care costs to go down so they're more affordable. And there are different ways to do that. They took one path, and there are other paths that will come through the regulatory process. So there are good things, particularly for children and families. There are good things in the legislation, and I've just kind of made a list of them. We have the lifetime cap limit lifted, which I can tell you that was a daily battle for us at Children's as we worked with families and individuals trying to make sure their children continued either on an insurance plan, or if they capped out, that they had access to something to replace it. So the lifetime cap thing was a huge lift. The pre-existing condition pieces are still being discussed, but those are huge steps in the right direction. And all of us as a pediatric community worked very closely to get a lot of these pieces going forward. One of the things, the very last thing that actually has not hit the radar screen of the states yet, is that there is language in there that would pay Medicaid providers, particularly the specialists, but it would pay your primary care and your pediatric specialists a rate equitable to or equal to a Medicare rate, which right now Alabama actually leads the country in fair reimbursement, but our partners all over the country do not, are way, way down. And so it limits access to some of those specialists, particularly for the Medicaid-enrolled children and adults. And as we talk about expanding Medicaid to the adult population, that will be even more important so that we get an appropriate continuum of care of services. What's missing? A lot, but there are a lot of pieces missing with respect to cost and delivery systems. The one thing we as a provider community are challenged by, whether it's a state agency or it's an a hospital or a doctor's office, is we have Medicare regulations and definitions that are applied to Medicaid. And if you think about geriatrics applied to pediatrics, both in terms of the frequency of therapies, the kinds of services that are covered, what's paid for those services, you're talking apples and oranges. So we have a real challenge both in terms of definitions and in terms of cost, because Medicare doesn't allow some things to be counted, or Medicare counts more than what Medicaid counts as cost. So how we keep a financial balance on the provider side and the service side, whether it's home care or whatever it is, how we keep those things in place and keep balanced will be significant as we go forward. The other thing, policies, there are a lot of details. There are 1,100 plus regs to be issued by the Secretary of HHS. 1,100 regs in the next 3 years. Only 100 of those have been issued, and not a single one of them has been less than 500 pages long. So there are a lot of details to come. There are a lot of definitions to come. The Secretary has an awful lot of power at this point. And the one thing we have a shortage of in the country are both nurses and physicians and nurse practitioners and those people who can help facilitate access. And that pipeline is shrinking, not getting larger. So we have a longer-term look-see to deal with called the medical and the community service workforce. Okay? So we have 1,100 rules yet to come. One set came out the other day, and I think it's 800 pages long. Our state budgets are challenged. We all know those stories. We've been reading the papers for what the challenges are with the Alabama state budget. And that will be a continuing issue as we go forward for the next 5 years. We have the states responsible for creating the insurance exchange structure, and I'll talk about that in a few minutes, and where the role all of us have to play. And then the provider reimbursement, not so much in Alabama, but across the country, is way below Medicare costs. So when you dump potentially 500,000 adults from Alabama into the system, the network of providers is not there because it pays so low. So there are not a lot of adult providers there. So we've got some balancing, we've got some smoothing out and balancing to do to get in preparation of the adults coming on board. Some of the other challenges are the health information technology, and I know all of us have gone through, I've gone through it with parents, I've gone through it with my sisters, as well as myself, and that is your medical information and having it accurate, having access to it, having one physician talk to another, or one's office talk to another office, those kinds of things. The health information technology idea is really accelerated both through healthcare reform and 2 other bills, but it's all of us in the state of Alabama, I can tell you, are heavily investing in technology where your experience or your encounter at the hospital is shared with your primary care physician, or some other, if you've gone to a doc in the box, whatever you've recently encountered will be connected. So we know kind of what's happened to you in the last 24 hours in case you show up, you need additional services, or something happens at home and it becomes an emergency. At some point the EMTs will be plugged into this, but it's a huge, huge investment. I do not know what the investment dollar is right now in Alabama, but I can tell you at Children's, it's, for 1 year, is something like $30 million. So It is not insignificant in terms of what we have to invest. The timeline we are required to have this up and running, though, is almost impossible. So I don't know how the federal government will deal with that. And then it's not recognized as a cost of delivering care. So it's not hands-on patient, but it's related to the patient. So it's not considered a cost yet of delivering patient care by the federal government. So that's one of those little tweak and tweeners that we're going to have to get worked out.